Today much more better for the patient. Let's see.
Good afternoon. I'm going to be talking about one particular type of phakic eye oil, that's the acryl phakic eye oil. Until recently, we had only one that was a star that was ruling the roost. And one of the things that they said was that the material they used was the only thing that was compatible inside the human eye. It had to be this artificial colama. Anything else would be a disaster. I think time has come to call them bluff. I think quickly I'll go demolish through a point of time. OpScan was thought of as the gold standard, and OpScans are not being used very widely. IOL must be brilliantly accurate. The Sirius appears to be very all along, both inside the bag and in the sulcus, and having extremely good results. Why can't you put this in with the same design? This has 4 holes. The parameters we checked, and all of them were done on the IOL Master 700, which gives phenomenally accurate values for both white to white, anterior chamber depth also. And this is the calculation that came from the company, the eye trace that was done. Forgive the quality of the video. This is done on purpose. This is the first ever acryl lens or other phakic eye oil done by my fellow. He's doing the first lens of his life. And just to prove to you, this lens is very user-friendly and anybody can use it. The loading is just like any other eye oil. The only difference is you tuck the eye oil where you make the lens concave. Here you keep the convex surface pointing upwards. That's the only difference. The same injector that you used to, no problem at all. I like to put a little viscoelastic at the back so that that acts like a cushion between the lens and the plunger. So you'll find this is kind of out of focus because it's being done by somebody who has not done it before. Hyaluronate. Once the lens is injected very slowly into the anterior chamber, put in viscoelastic on top. Any one of us can do that. We have 2 side ports that are already there. Go in, gently tuck the 4 loops back in. Again, remember, the person who's doing it is doing it for the first time in his life. Of course, he's seen me doing quite a few. There's no struggle. In goes. And at that point, both went in. When he put in the one lower, the second lower also went in. He prefers to come in from the other side. I would have done it from the same side. It's as easy as that. And that is it. Tap down the lens. Don't go by what star says. Don't touch the lens in the center. It will tear. You should not cross the lens. You take the instrument across the lens. You're doing some sin. Nothing of that kind. Go in, keep the port turned down, and go to the hole and take out the viscoelastic from behind the lens. You can see that coming out quite clearly, that flower-like thing. Go all around, bring out all the viscoelastic. It's as easy as that. So all you need to do is a refraction, anterior chamber depth, white to white, K value, go to the site, do the calculation, or ask the company to do it, and they send you a lens. Loading is just something that you're used to, the same injector, no difference, no other kind of pushers that you need, and that's fine. You can actually see the viscoelastic coming in from behind. So post-op day 1, you can, unfortunately, I don't know, I can see it so clearly here, the vault, and it's not seen very well. The vault was about 600 microns. And you can see it quite well on the anterior segment OCT. Even here, it's much clearer on the computer than what you see there. You have a vault. And there you see, both eyes improved to 6.9, where the previous improvement was only 6.18 and 6.12, we improved to 6.9. So it's very easy to load, very good stability, very user-friendly, proven hydrophilic material. It's available in higher dioptric ranges. It's stable visual results over 1 year. Endothelial cell counts are stable over 1 year. The vault remained stable over 1 year. The only difference was from 0.58, it dropped down to 0.53, which is nothing much. Intraocular pressures were absolutely normal over 1 year. So take-home message, here is a lens that's user-friendly. Anybody can use it. Putting it into the injector and shooting into the eye is quite simple, tucking it in. The only issue, you need to have a well-dilated pupil. Thank you.
I have two questions, Dr. Okay. How long have you been using these lenses?
About a year since it came in the market.
Okay. And is there any patient where you felt that something was not proper with this?
Absolutely no.
No cataract, no
No,
uveitis?
absolutely. Now, let me tell you now, cataract is going to come only if you have the crystalline lens and ICL touch.
Touch, yes.
Sometimes in very high dioptric powers, the periphery of the lens, even the minus lens, is thicker. Under the iris, you could have a diopter. Your touch could be there. So you have to be sure of that. That's the only issue. So you can't. Okay, that's another question. How much shallow AC can you go on? I've gone up to 2.65 with a star. I've not gone on here. But when you try to put in a lens in a shallow chamber, you have to lie to the company, because when you give a figure less than 2.8, they won't send you the lens.
They'll reject it.
So we'll have to now take the risk. I've gone down to 2.65, but made sure that the angle was fully open.
Absolutely.
If I had a 3 mm anterior chamber with an angle that looked dicey, I would not put the lens in. So pre-op preparation is essential.
What is the price advantage with this lens for us?
Huge. Again, I think time has come for us to start using Indian products. Today, when I do flax, 50% of my flax is, when I put multifocal, is Indian trifocals.
Absolutely.
Indian trifocals. They're so much, they're brilliantly good. And they cost half of the imported multifocal cost. So I do flax and put Indian trifocals, and that's fantastic. I think somewhere we have to now start learning to move into using our products. We are catching up. We are catching up, and unless we promote the products ourselves, we are going to go nowhere.
Yeah, thank you very much.
Thank you.
Compared to IOLs, with respect to ICLs, the cost is a major difference. Otherwise, technically, it's very simple to do ICL. But many of us are not using just because of the price, nothing else. So I think it's a ray of hope that we have available Indian phakic IOLs. Invite Dr. Kamal Kapoor, one more Indian product, IPCL, long-term experience with IPCL.
Very, very good afternoon. I must thank Netradhama. I'm not there. Yeah. And Sheetal and the whole team from Netradhama. I had to make a quick rush here. I believe there was a huge traffic jam, but never mind, I'm here. I would just like to add what Dr. Arul said. Patient comes to us because of what we deliver. Patient has never come to me because I use a particular lens. Patient has never come to me because I use a particular machine. Patient comes to me because I deliver what I promise. So let us take the credit where it belongs. Let's stop using much of these multinational products. I'm here talking about a lens, IPCL. I think Sanjay Argal is here. I think I was one of the first people to use it. And I'm one of the most ardent admirers. I think probably one of the highest volumes in the country. I'm not sure. Long-term experience. What is long-term? Since the time lens started. So nearly 4 years, I've been using this lens. Options, variable options available now, but when it started, it was a lone crusader. I was using a lot of ICLs. I had issues with ICLs without getting into that. Mainly not with the product, but with the supply, the way it was supplied. So at that point, I think that was a sweet spot. People who play golf or cricket, they know there's a sweet spot in the bat. There was a sweet spot for this company to enter into my organization. And after that, I think we took long. So there are various options available for us. I have used the lens by Biotech. I have used a lot of lenses by ICL. They are all good. I will not get into the details. I would say it's a fantastic design, and it has evolved as it is coming from where it started and where it is now. I have used more than 1,000, and I have long follow-up of nearly 4 years now. Simple logic, there are 2 holes which you always have to keep at the top. So when I tell my trainees that point these 2 holes at the eyebrows of the patient and the leading hole on the left. So it is lid, upper lid, and the leading hole. That's it. Keep it on the left. So L, L, L. I still do PIs. With the new model, I don't use the V2 much, but now I'm going to start using V2. I'm a big fan of the V1, which comes without the hole. I normally do my PIs 7 days before the surgery. So, you know, indications, we all know, I will not get into it. High refractive errors, of course, yes, is an indication, but there are a lot of other indications where you would want to help these patients. Experience, more than 1,100 cases done, more than 4 years. I usually do PIs 7 days before. I've corrected whatever you can think of. And I must thank Sanjay Argal here. He's made lenses for me at 8.5 millimeter of optic size. Can you believe that? I'll show you some videos. 29-34 myopia, hyperopes, +8, +6, cylinders up to +9, corneal scars, name a thing. I've used it as a secondary piggyback. I've used it in patients who were operated when they were pediatric cataracts. They are landed up with -11. I've put these lenses as a piggyback lens. What are the issues I encountered? Out of maybe 1,100 plus patients, I will say cataract, one was post-trauma. One patient got into a fight and he got punched in the eye. He came to me 4 months after the fight. He had a cataract. I had to remove that. 2 explants were due to bad sizing because the lens was touching the crystalline lens. Again, mistake as we move along. One of my optoms reported a wrong size. Then it made me put some more protocols in place, which we'll discuss. 2 had very high vaults. But one good thing is, which I've seen and I keep discussing with the R&D team at Care Group, I've seen if the ACD is more than 3.5, you can get away with even 1,200 microns. 1,400 microns I've got away with. But 2 cases I had to explant, as Dr. Arul said, the angles were going bad. It was not the vault which was troubling me, the angles were tricky. So size and power, extreme sizes, powers are available. 14, 11, 11.5, whatever you want, +8 to ±30, decimals of 0.5. The best part I love is my toric patients do amazingly well. I repeat, I do not need to rotate the lens. I just put it at 0-180, that's it. The lens comes manufactured according to the patient's astigmatism. One of the most happiest refractive patients in my armory are my phakic patients where I've done toric IPCL. It's a smart lens, just put it at 0-180 and it's bang on, no need to rotate. Everybody with even eyes closed can do it. Cross-check, a lot of times these things can happen. I'll just run a video. A lot of times you use a Cirrus or an OBSCAN. I trained my optometrist to counter-check manually. So you'll see, this is what the machine gave. This was larger than normal. Just counter-check. Train your team to do that. The only problems you will ever have with the phakic lens are bad sizing. It's never the refractive error. Bad sizing is the only problem you'll have. So perfect that art. I'll show you how we do it. Perfect that art and you will go bang on. So once you do that, you see the size changes. From 13.25, suddenly it came to 12.57. This was going wrong. So I realized what was going wrong. I had 2 or 3 bad sizes. I sat on the machine and I saw sometimes there's a little scar near the limbus. The machine automatically recognizes it at the horizontal, vertical, visible iris distance and gives you a wrong size. So that's one. Pupillometry is very important. We do not talk about pupillometry when we do phakic lenses. So I've trained my team to do a regular pupillometric evaluations. I will not show the videos now. We'll just jump there. Now here is a presentation. This pupil size is 6.75. Now lights are switched off when they are done. Because most of these high myopes will have large pupils. So you cannot get away by putting a 5.75 or a 6.2 millimeter optic size in this patient. He's going to complain of glares and halos. And he'll eat your head off. So pupillometry measurement is a very, very important thing which we are not doing regularly. Now another thing is, in case you don't have these hi-fi machines, in some of my centers what I've started doing is, I've started using these autorefractometers to measure the pupil. I'll show a video if I can play it, and to do the limbus. And once, if everything is done, there's a cross-checking. The only thing which is cross-check again and again is horizontal, white to white, white to white, white to white. So we use 3 methods: calipers, Cirrus or an OBSCAN, oblique, if it's not available in the center, with an autorefractokeratometer. Marking of the cornea has to be accurate if you're going for a zero astigmatism. This is one of my standard favorite methods, 0-180 marking. Toric marking, now, look at the case study. -16, chicken feed, nothing, not an issue. This girl is nearly spherical equivalent, just see this. -29. Look at the glasses. Look at her face now. This is what we can do to these patients. Look at this boy. And look what he looks like after the surgery. So this is now available, and Indian companies are making this. Now this is a classical case, a large pupil, 7.26 size pupil. One brother has got operated, he's happy, he's got his younger brother for the surgery now. Now this is a classical example of a diameter of 8.5 optic size. This is huge, but it works. This patient has a resting pupil size of 7.46. So went for an 8.5. Look at the size of the ICL. Now look at the extremes of powers available. 14.5 millimeter lens sizes available on request, on demand. Now let's see some videos. I think I will not show the video, regular video. This is the best part about this technology. You don't need to do anything. Just put the lens at 0-180. That's it. No rotations. There is a mark on the lens which tells you that these two marks, align them with the marker, and that's the end of it. I'll just show, this is again a video of this is an 8 millimeter lens. I'll just go fast and see the size of the lens. We'll jump the video. Look at the size of the lens. But centered beautifully. Volt was perfect, 750 volt. The patient had an ACD of 3.2. So everything is perfect. Toric lens. Again, now this is the lens which is longer, 14 millimeter lens. I'll just show you the trick. At times this can get stuck in the wound. So a lot of times don't push it all the way through in. Go halfway, leave the last trailing part, and that you can manage. I'll just go to that part of the video where that's. So if you have a very large lens, don't try and push it through straight. You might cause some bleed there. Leave it like this and push the last part. Just withdraw your plunger. So these are tricks which I evolved as I went along. So I'm becoming more adventurous and things are becoming far better for me. This is one patient where I needed to explant the lens. You can see anterior cataract coming in. This is blunt trauma. This is interesting. I'll just show this video and we'll just skip. Now this patient had a trauma. You see the lens has moved down after the punch. There's a cataract. So I decided to do the whole cataract surgery without taking the IPCL out. I've done the whole surgery, done my rexes under the IPCL, hydro under the IPCL, Phaco under the IPCL. Everything is done under the IPCL, and once everything was done, then I removed the thing. Now people will ask me why. Because to remove this lens, unlike a star lens, you can get it out of 2.8 again, or even 2.6. You need a 3 millimeter wound. So once you want to do a 3 millimeter wound in a high myope who's minus 19, you will have chamber fluctuations, you'll have iris coming out, a lot of stuff. So I wanted to avoid that. So I did it through 2.8, and just for removing the lens, I enlarged it, and then I put my new lens in. So there, I explant the lens after the cataract surgery is done and push in a new multifocal for this patient. This multifocal again is by the same company. I use nearly 100 plus multifocals from an Indian company. Amazing results. So this is again hypermetropic patient. Difficult to put the haptic behind the thing. But again the trick is I use the center first because this lens comes with 3 legs. So I push in the middle leg first behind the iris. Once that's done, what it does is pushes the iris behind. So then the other 2 are very easy to go. So in patients you have mid-dilated pupil, hyperopes with smaller eyes, a good idea to put in the center loop first and then put the peripheral. So there you are, and I think, trying to go fast. Now I have also done phakic multifocal IPCLs. My first patient was my OT technician. Sanjay is laughing there. My OT technician, I did cataract for him 8 years ago. He could never bind the rex's needle for me. So he said, sir, aap sabko multifocal dalte ho, mere ko kyun nahi dala? So I called up Sanjay. I said, can you make a lens for me? He was minus 1.5 still. So he made a toric, multifocal, piggyback IPCL for him. Now my OT technician, both eyes operated. He's got piggyback, multifocal, IPCL in both eyes with toric. And he does all the right instruments to me at the right time. Thank you.
Thanks, Kamal. That was wonderful. I've also been using IPCL for quite some time because it's the next best alternative to ICL. The only difficulty that I have is the haptics are very thin. They're extremely thin, and sometimes they bend on themselves. You have to be very careful that after you insert them, you make sure that the haptics are not bent on themselves.
I think it's a wonderful tip. And one video which I skipped, normally I saw one vault which was going, if you notice it said it was due to a folding haptic. So now once I finish the surgery, I push viscoelastic on the IPCL and I just go on the edge and I just softly rotate both the sides. Since the haptics are very soft, there's a purpose to that so they don't damage the zonules. Just make sure that they are properly unfolded and it'll do the job.
The other thing is, other important thing that I think I told Mr. Sanjay also that, now they have come with the center hole. they have shifted their hole size or the type of holes. I mean, it's hardly visible underneath the microscope. So I told him, make it easier for the surgeon. One is inside, that heart-shaped thing is inside. The others, in this, it comes outside.
That was one reason I was not using much of it.
It is very difficult to see under the microscope. I was telling him, I'm suggesting him, make it very simple. Just one hole is enough, and make it on the right or left, whichever you want. Makes a lot of sense to us.
Right, Dr. Sajja, how do you make out that it's not folded, and what is your way of checking there?
I go under the iris and check. If I'm not able to see it, I go under. Because I had a patient who was, the volt was very high. I was wondering why, because everything else was okay. Then I went inside and they had to unfold this. It was like this.
So you use a Coughlin hook to lift the iris, basically?
Yeah, I use a Coughlin hook or a fork.
Can I step in here? Yeah. What I do is I just push viscoelastic on the IPCL. I don't need to lift the iris. I use a lupus dialer. I just go on the edge of the haptic, softly put it on the edge, roll it once or twice. If it's unfolded, you suddenly feel a snap, it'll go down. If it is not, you're bang in place.
I would prefer to see it because I had a bit of experience in one patient. So after that, I had to go in again and unfold the haptic.
Okay, that's a good point. Now we have Dr. Partha Viswas. He's going to teach us how to do ICL in the correct way.
And also the complications of ICL. So Sheetal wanted me to speak in 10 minutes, complications, and to do ICL the correct way. Fine. So I'm going to just show you a few video clips on how to do ICL the correct way. And so this is loading of the ICL, and this is the most important part of the whole procedure. Implanting an ICL is not so difficult, so it needs to be taken out of the vial, which is lodged in BSS plus, and it needs to be placed into the cartridge with the viscoelastic and the BSS there. So once there, and there's a special forceps from the STAR ICL people, and this is the Osdior forceps which draws out the ICL into the cartridge. And then after that, it is loaded on to the injector, and with the injector on, this ICL is ready to go. So you just need to make the two ports from the sides, the two side ports come in. The viscoelastic amount is to be graduated, just enough for these streams to disappear, merge into one another, and then placing the ICL. So the main port is just 3.2 millimeters. You snuggle in. The injector nozzle has to go inside the anterior chamber. You look for the right hole, and the right should be the leading right. So once that is in place and you are able to see the top hole all in the center, that means that the ICL is going the right side up. So once the ICL is right side up and it has been injected, all that you need to do is to place these 4-foot lenses inside, just untuck them under the iris. So once tucked, this sits in place, and if it is a toric ICL, then it has to be oriented to the axis. So this much for the ICL implantation. Now we'll go on to the complications of ICL, which is something that and this is again a series of videos. So over the years, all these videos have been accumulated, and we have sizing issues, high vault, low vault, post-operative intraocular pressure rise, which can be controlled medically, upside down ICL, which have to be corrected, damaged ICL have to be rejected. Lens touch with cataract formation. If it is just a small subcapsular cataract, you don't need to worry about it, and these cataracts usually do not extend. If there's post-operative glare, wait for the good old neuroadaptation to take place, and it's only in those very, very difficult patients or difficult individuals that you might need at any point of time to remove the lens. Pigment dispersions are usually not an issue, and the ICL has the fibronectin cover. Rotation of a toric ICL, if it has gone out of the way, it can be re-rotated and can be placed in its place once again. So this is a small video clip, and I'm going to run you through these video clips. And here what happened is there was less of hydration of the applicator, and the ICL, one of the foots, have got stuck. Now, it got stuck, this is a small clip, but it got stuck for nearly 7 minutes, and I was struggling through those 7 minutes to put in that ICL, the foot plate, inside. And once inside, of course, the implantation is not so difficult, but in these cases, sometimes the pupil starts going down. And when pupil starts going down, can I have the pointer, please? When the pupil starts going down, then you need to be quite aware of this fact, and only when the pupillary area is well and placed, you can tuck in the haptics. Now, in this patient with a mid-dilated pupil, this pupil was not dilating, and you can see that the iris is popping out. With the iris popping out, you have to be very careful. This iris can be traumatized badly if it is not carefully done. Unlike where in the intraocular lens placements for cataracts, we cannot take off this iris tissue from the side ports. So what has to be done is the amount of viscoelastic that has inadvertently gone under the iris has to be weaned off. And that's the most important part of the whole procedure. Once that is weaned off, then you can very safely tuck in the iris into its own place. And placing the ICL in its place is not so difficult, but you have to maneuver it. You have to have good amount of viscoelastic cover between the ICL and the corneal endothelium. This is a stuck ICL. So what I had done is, while injecting it in, this ICL, the injector got removed a little early, and you can see in the main port, the ICL is stuck. So in the main port, since it is stuck, so what I have done is I've placed in viscoelastic to support the ICL, and I'm really scared that it goes upside down. I'll have to take out the ICL and again replace it. So what I'm doing is, with one spatula, I'm holding it so that it does not. And with the other spatula, I'm trying to push it in through the main port so that it unfolds the right side up. This again took the best part of about 8 to 10 minutes, and all this time, the heartbeat was in full pace. So once it unfolds, of course, the next part is not so difficult, and you need to put in the haptics in their places. So this young gentleman, what he did is he gave his eye a good rub, and the orientation of the toric ICL went out of place, and you can see it is longitudinally oriented, and it has gone at approximately 90 degrees from the 180 degrees position. So we remark the toricity and we reorient. Just remember the fact that during the replacement of this ICL or placing the axis, we do not have the cushion of the viscoelastic between the crystalline lens and the ICL. So it has to be a very, very gentle rotation while this is done. And once this is done and it is not an issue of undersizing, then these lenses stay very much well in place. The next one that I'm going to show you is, of course, an ICL exchange, and this ICL had to be exchanged for another one. And I have placed in high molecular weight viscoelastic to support the corneal endothelium. And the first thing that I do after placing in the viscoelastic between the crystalline lens and the ICL is to remove the tuck of one of the foot plates, and grasping the foot plate beyond the foot plate and to that portion of the ICL which is thickest, and that's the rib of the ICL. And once that is caught, you can actually pull it out, and once it is pulled out, then with two other forceps, and these are Pierce-Hoskin forceps, hand-over-hand technique, and the whole ICL can come out through a 3.2 millimeter incision. So once it is out, you need to place in the right lens in. But during this procedure, the maneuver of the iris, what happens is there is definitely an amount of meiosis which is created. You need to put in viscoelastic and see that the tucking in of the next lens is atraumatic as possible. And all this can be done very well under viscoelastic cover, and for this methyl cellulose is definitely what I use. You can see that the amount of maneuver that needs to be done, but if it is done gently, then the cataract is change possible. possibly will not occur. So you can see that it's a very mid-dilated pupil, and on ordinary routine case, pupils should definitely be larger than this for a good procedure. This is a young patient of mine, and he had undergone the ICL surgery. He got a job in the police, and he was so happy. Then he developed retina detachment, and with the retina detachment, my retina colleague took it up and did a very good vitrectomy and silicone oil, but there was a lens touch. And with the lens touch, in about 3 to 4 months' time, this is what happened to the lens, and it's a full mature cataract, Morgagnian cataract. And there was an amount of synechia also of the iris to the ICL. So what we need to do is to take out the ICL, which again is not so difficult, and it is to be removed through a 3.2 millimeters incision, which we are able to remove. And again, hand over hand technique, and removal is not so difficult. So it needs to have an incision size that is just adequate so that the iris doesn't pop out, and it can be taken out. So the forceps are very important in these cases, and atraumatically they can be removed. Just like the previous case, we remove the ICL. And the next part is, of course, removal of the whole of the viscoelastic so that we can stain the anterior capsule well. But then is when I have the trouble. So I'm trying to make an incision and trying to remove the amount of cortical matter, which is a liquefied cortical matter, from the inside the bag. And after doing that, I need to do a complete rhexis. And if the rhexis is complete, the job is done. Remembering the fact that this was a lens touch and there would be more problems on the way. So as I go ahead to do the rhexis is not complete and it runs out. So once it runs out, I'm not able to retrieve it, and there are possibly 2 places in which it has run out, and so I remove the amount of cortical matter, knowing full well that the rhexis is out, the cortical matter, remaining cortical matter is taken out, and what of course we had apprehended is there is this plaque that is there centrally, and this plaque has to be negotiated. So the plaque that is there is dead in the center, and it has either to be removed or an opening needs to be made. Remembering the fact that the anterior capsule has run out and the posterior capsule has to be maintained, we put in a 3-piece lens which possibly will go into the sulcus, and the pupil is of course crowding in. So once the lens is placed, so what we do is we take the MVR and make an opening in the plaque. Now the central portion of the plaque has to be cleared, and this is very important. If the clearance and if the vitrector goes in beyond the central portion, if it goes into the posterior capsule, which is transparent, this posterior capsule might rip off and might meet the anterior capsule tear, and we'll have a lost bag. So, but this done well, and the anterior capsule has been nicely cleared, and we are able to place the lens in the bag and lens in the sulcus and clear up the posterior capsule. This I will skip this video, and I think the last one is, I'll just show a small clip, and this was a very unfortunate patient in which the surgeon was doing his surgery for the first time, and he put it upside down, did not realize that the ICL was upside down. He tried shoving it in, and this is what had happened. So there was endothelial touch on the periphery, there was lens touch in the center, and the lens, there was a huge amount of reaction. It took us 3 months for the reaction to settle, and ultimately we had to explant the ICL, of course, and you can see that there are 3 sutures that he had placed in. These were on the temporal side. So because the amount of trauma on the cornea on the temporal side was so much, so we attempted to take it out from the nasal side. So we removed this ICL, and it is a long process. It took me nearly half an hour or so to remove the ICL. Because one, it was jammed, and I was really apprehensive that possibly it had gone and had possibly ruptured the zonules also. But we were able to remove the ICL, and I'm just fast forwarding the video to as much. And once we are able to get it, we decided not to go ahead for a cataract surgery in this case. This is the most traumatic experience of mine for explantation of an ICL. But once removed, we just cleared up. There was fortunately no vitreous in position, and we removed off the viscoelastic. Let the patient be, but unfortunately the patient did not do well, and there was intense reaction which was still there. We fought on a lot, but there was decompensation, endothelial decompensation, plus ingrowth of the epithelium, and we lost the patient to follow-up. Thank you very much for your patient hearing, and thanks to Netradama and Phaco Festival.
It was a fantastic overview of all the complications that we can have. Though it is a very, very simple surgery, for anyone who does a cataract surgery, phaco foldable is very simple, but there are very important principles that you have to keep in mind. And as long as you do that, I think the success will be excellent. Thank you.
Thank you.
I think we are coming to the end of this session. Thank you, Dr. Biswas.
So thank you all the speakers. It was a very valuable inputs, and the session was really informative. So now I kindly request Dr. T.K. Ramesh to hand over the mementos, please. Sir, I kindly request you to hand over the memento to Dr. Sujata Mohan. To Dr. C.A.P. Prabhu. Dr. H.M. Ravindranath. Thank you, sir. So now we'll be heading for a short tea break. So we'll be back for the next live surgery session in Hall A at 3:30 p.m. sharp. Thank you.